Hello, I'm Lucy. I work at Women's Health Tasmania, and before we get stuck into the first ever episode of Speaking of Health, I want to let you know two very important things. First of all, we made these episodes with input from a crack team of trans and gender diverse advisors. This incredible group of people have experience accessing healthcare right here in Lutruwita, Tasmania. So their stories are very much of here. But wherever you're listening from, there'll be useful ideas you can take with you into your work in healthcare. The second thing is thank you. We know your time is precious, and we know there are a lot of podcasts out there. So thank you for making it here to Speaking of Health. All right, on with the show.
Well, I have a really good GP now.
That's Oliver. He is a local Tasmanian. He loves our rolling hills. And like all of us, he sometimes has to go to the doctor.
Waiting lists being what they are, I've had to sort of step out occasionally from my safety bubble of well-educated and aware people into the unknown.
Oliver had an infection and he waited for it to get better on its own, but that wasn't happening. So he did what we would all do. He made an appointment with the first doctor that he could see, someone he'd never met before and who'd never met him.
It was the very end of the appointment when he asked me if I would mind clarifying. So he said, "Are you a man or are you a woman?"
What would you do if someone asked you that question? It's one of those questions that we know just from sort of how it sounds, that it's, maybe a bit rude, overly personal.
And then it was only afterwards that I twigged to the fact that I don't think he was asking me what I had assumed at the time. I think he was trying to ask what my assigned gender was. Looking back on the situation. And that's not what I told him. I told him what my gender experience is.
I can tell you right now, if you work in health, you are definitely working with trans and gender diverse patients. Statistically, it's just inevitable. And that question, are you a man or a woman? It's actually an iceberg. The man-woman bit, that is just the tip. And underneath, under the water, there's a lot to talk about, especially when we're talking about getting the right care for trans and gender diverse patients.
If that had been in an actual medical situation where that was a required piece of information for him to be able to do his job, who knows where that could have gone? He could have marked the wrong thing down and something relevant will be missed.
Speaking of health, I am really glad that you're here because it means you want to take on a thorny issue in healthcare. And let me tell you, this one is a doozy. It's all around us. It colours the way we see the world, and it has big impacts on the care we provide to trans and gender diverse patients. It is the gender binary. What do I mean by that? Well, it's the belief that there are only two genders, man and woman, and that they are determined by a person's biological sex. And one of the ways that the gender binary shows up in healthcare is through gendered medicine. But how do you support a patient who doesn't fit into one of the two boxes that gender medicine holds out to you? We sometimes hear from GPs that they don't know how to support their trans and gender diverse patients. And if you feel this way too, let me tell you, you are not alone.
I had one lecture on trans and gender diverse health in med school.
Okay.
Yeah.
Okay. So that wasn't enough. That's
Oh,
what I'm hearing.
No, of course it's not. How are you supposed to really represent the complexity of health needs of a community in a single lecture?
Like so many GPs, Dr. Miranda Hann, who's a GP registrar in Lutruwita, Tasmania, wasn't really taught a lot about trans and gender diverse healthcare as part of her study, at least not formally. What she was taught a lot about is gendered medicine.
In medicine, you're taught about sort of gendered anatomy, right? And cisgendered diseases related to said anatomy. So, for instance, breast cancer is taught about as being a cis female-bodied issue, with a small mention that, yes, it does sometimes happen in cis men, but not commonly.
That word Miranda is using, cisgender or cis, there's more information about what that word means in the show notes, but the really short definition of it is that a cisgender person is someone who is not trans. Being cisgender is very, very common. It means that the gender that you were assigned at birth is the one you still identify as now.
And so when you're studying medicine, you have a urology rotation, a urology section of learning, which is not all, but mostly related to male urological disease and a little bit related to female urological disease. So urology is kidneys, ureter, bladder. Urology also takes care of things like prostates and testicles and testicular cancers, which is why we often get a lot more male presentations within urology. Then you're also studying women's health. And so women's health is typically like OBGYN, so obstetrics, gynecology, and pregnancy is a big thing, and pelvic floor issues, and anatomy-based cancers, so like uterine cancer and cervical cancer and breast cancer and those kinds of things. And so those units are separate and they're taught separately.
Which makes sense. Different diseases, different life stages that relate to different biologies. But Miranda tells me it has big implications for trans and gender diverse patients.
Then when you get into real medicine and working in real healthcare spaces, you're not necessarily seeing cisgendered people. Sometimes it means that when patients are accessing healthcare spaces, which are already a vulnerable space, and then having to disclose really vulnerable information about anatomy, especially people who are trans and gender diverse, it can heighten that anxiety and heighten that vulnerability in those settings because you're exposing bits about yourself that you don't want the provider to know, but they need to know for the purposes of your presentation and why you're showing up. So it can be a really hard experience for a lot of people and potentially really damaging and harmful depending on how somebody is treated.
What Miranda is saying is pretty concerning, actually. We use the word vulnerable a lot in healthcare spaces, but what does it actually mean? What does it mean for their care? What does being damaged by the care you receive mean? And what does it feel like to be vulnerable?
I think there's a element of dissociation that you kind of like draw on to be like, I'm just going to send my body through this process, and if my whole brain isn't there, that's okay, because that's part of making sure I'm okay.
As you can hear, Oliver is a confident and articulate man, but when he goes into health spaces, he feels vulnerable, and he has to do this dance between detaching and staying present.
I need to be kind of on the ball enough to be able to, take control of the situation and try and get the healthcare that I'm after. Yeah, it's probably just having a bit of brain white noise until it's the moment to say the things.
Oliver had to say two things. First, help me, I have a UTI. And second,
I'm transgender, by the way, or something like that. Like I was just shoehorning that bit of information in to be like, in case you haven't read the file, which happens. He was typing stuff in or, looking at his desk and so on, and he probably like turned to nod a little bit at what I had said and then turned back to what he was doing in front of him. So I'm not unfamiliar with UTIs. I am AFAB. I was assigned female at birth. This is a thing that is a little more common to folks on our end of the scale. But it is unusual or less usual for a MAB, so assigned male at birth person, to present with UTI symptoms. So there was automatically a little bit more concern
The doctor did some tests and prescribed Oliver antibiotics for the UTI.
A number of days later, when my usual GP was available and had seen through the internal records, however that works, what had happened and the kind of script that I'd got. And so she phoned me to say, how many of these did he say to take? And I had a packet of, I think it was 7 days worth of medicine, where apparently all I actually needed was 3 or 4 days of it because of the length of my urethra.
When it comes to UTIs, the care, as in the amount of antibiotics you prescribe to treat the infection, may be different depending on the length of the person's urethra. And often people with vulvas, or who might have been assigned female at birth, have shorter urethras than people with penises who might have been assigned male at birth. What Oliver's doctor missed in this situation is that the clinical treatment needed to take into account Oliver's biology while still being respectful of his gender. As we'll see later, there is a way to do both.
Oliver, what went through your mind when your doctor told you this?
A frustration, I guess, that I thought I had done what I needed to do to have communicated enough, and it turned out that wasn't the case. Transgender to a lot of people means trans women. And so what I could imagine perhaps is that maybe he interpreted me as being AMAB with a trajectory that I just started of transitioning.
Oh, so he thought that maybe you had been assigned male at birth and you were going to transition.
That's quite possible. I mean, I can't tell you what exactly he thought, but it's not unusual. And I've had trans men friends of mine who have got the whole full beard and everything when they're, someone said, well, you're going to have to do a lot if you're trying to be a woman, to get rid of all your beard and all the things that they could imagine that you'd have to do. Because trans men just don't register as often or for as many people as being actual people with that kind of experience. And just kind of reinforcing how careful of what extra things I need to be prepared to be able to do and say to advocate for my health in those situations.
Oliver explained to me that it's kind of common that GPs will expect a transgender patient to explain what it means to be transgender.
What is it like for you when you have to do that teaching of medical professionals?
It's draining. You don't know when it's going to end. You don't know how personal it's going to get. And you don't know what the emotional reaction of the person that you're talking to is going to be. And that's scary. And having to navigate that, day in, day out, or to navigate that when there's already a power dynamic, like a patient-doctor relationship, and it may impact the way that you're able to access the care that you're there for, it's not going to be the best place for the right information to even come over. It's great that people want to know, and it's important that people, have access to things like this show, for instance, so that they can get some understanding without putting the pressure on any individual to be ready to do that work.
The good news is that we don't actually have to rely on individual trans and gender diverse patients to educate us during their appointment time. I spoke to Dr. Miranda Hann again, and she had so many good ideas and so much advice, and I've taken the liberty of sorting it into 3 broad categories. First up, creating safety in the doctor-patient relationship. Dr. Hann explained to me that while you can do a lot within the 4 walls of the consulting room, it's also important to be attuned to what patients might be experiencing outside of that room.
I can control my room and I can control that bubble, but I can't control the other patients who are in the practice. I can't control who's on the street before somebody walks in. Sometimes we get new staff, or sometimes our staff does make mistakes. I do my very best to make sure I can create as much safety in all that environment before getting to my bubble. But sometimes I can't, right? And sometimes it's not a helpful experience. And there's certainly some of my patients are really awesome and give me feedback when things go wrong. And so it is feedback that I make sure to always pass on to the staff that I do work with to try to sort of have continuous improvement within my own team.
There are some things you can influence, like maybe how your practice as a whole is working in this space. And there are some things you can't, like if your patient is harassed or yelled at in the street before they come into the appointment. But you can be attuned and empathetic and help that person feel that they are now somewhere with someone who cares about them. And that can help restore someone's sense of being in a safe place.
So how can a GP get closer towards being that safe person or be better at being that safe practitioner?
Yes, super easy. You just have to use somebody's name and pronouns properly and treat them as you would treat anyone else. We treat people respectfully in our clinical settings all the time. And when people come in for headaches, we don't ask about their anatomy. And so using those same principles with trans and gender diverse people when they show up in front of us.
And it is that easy. But we just need to point out that while some people will legally change their name to the name that suits them better than their birth name, not everyone will, and not everyone can. The person might be too young, not have the money to do it, and people who are here on visas legally can't change their name until they become permanent residents. You've got to have a space in your paperwork where people can put the name that they want you to use. And you need to check for it and use it. We may eventually have the technology to simply download it into our brains, but that day, unfortunately, is not today. So we need to check. Another practice point that's worth honing in on. When Dr. Miranda before said that we don't ask people about anatomy when they come in for a cold, what she's referring to here is a concept called inappropriate curiosity. This is where you're asking a question not because you need to know for clinical care, but because you're just personally curious. Or maybe you want to learn from your patient for your professional development. Either way, you've veered away from your role in this patient's life. It's a form of inappropriate curiosity. The good news is there's a suggestion in the literature about how to avoid inappropriate curiosity, which is simply to ask yourself, why do I need to know this? If there's a clinical reason for the question, you can ask it. But always make sure you explain to the patient why you're asking the question, because a lot of trans and gender diverse people will have experienced inappropriate questioning or inappropriate questioning from a health professional before. And so explaining why you need to know the information will help them know that you're asking for the right reason. All right, next cab off the rank, the referral network.
Honestly, one of the biggest elements of making sure that you're a safe provider is getting a really good referral network. I often will have conversations with providers that I don't know ahead of time to make sure that they are going to be safe. And so particularly some of my allied health spaces, I've had some pretty extensive conversations with a few people and have established some really great working relationships with some of the networks in Tassie to make sure that I'm sending people to safe spaces.
So what if you need to send someone to a new provider and you haven't actually had time to suss out how ready they are to provide an inclusive service?
I'll often write within the referral perhaps a little blurb around this person has high health anxiety and I want to make sure that the correct name and pronouns are used, or I'll write, intimate exam has already been done. Please don't do it unless absolutely necessary. Whatever other advocacy I need to put into that referral to make sure I minimize future harm as best possible. Sort of the introduction section with the person's name and date of birth, and I'll add in the name that they use in quote marks. And then the referral will say, "Thank you for seeing Joe Smith, 31-year-old, for X, Y, and Z." But I'll add in 31-year-old, comma, pronouns, comma, for X, Y, and Z. And that way, that's right at the beginning of the referral. And it's a way for me to advocate for my patient before they show up to a space so that the provider that they're walking into should know the correct way to address that person.
So GPs ensuring that where the person goes to next is going to be welcoming, safe, and is primed to use the correct pronouns and name of the patient means that patients have better experiences in healthcare. And if you really want to ensure this, Miranda says there are certain things you can do on referrals to set your patients up for good experiences, with the patient's consent, of course.
And I often actually show the patient the screen, particularly my new patients when they come in. When I send my first referral, I show them the screen and say, "This is how I do my referrals. Is that okay?" And usually the answer is yes. I have had one sassy kid who corrected me and said, "No, I'm 11 and a half years old, not 11. So I did adjust their referral for them so that it appropriately matched their age.
Sassy kids aside, there is one more strategy that is going to help you out immensely. Ask questions of the right people. While this area of practice might feel new, there's actually a lot of GPs and specialists out there who've done the hard yards and want to share their knowledge with you.
So there's good support networks like AusPath, which is the Australian Professional Association for Transgender Health. There's a listserv if you're a member of AusPath, and you can ask questions on that listserv. And there's really great community and network of health providers there. And so you'll often get responses from endocrinologists, dermatologists, surgeons, other GPs, psychology and social workers, depending on what your question is. Asking the question and going back to the patient is often a really good way for us to make sure that we're doing the right thing, and it's something that we do in medicine all the time. If we don't know the answer, we're not going to necessarily do anything that day, but get back to the patient another day after we've figured out what we're supposed to do. And that's just because healthcare is a really broad topic, and we're not always going to know the right answer. There's some really great educational resources available. So I mentioned AusPath, which is the Australian Professional Association for Transgender Health. So they just published a informed consent model of care, which is a really, really clear and easy to read document on how to start and prescribe gender-affirming hormone therapy for patients. It's excellent and a really easy place to start. Additionally, in that space, the RACGP, which is the Royal Australian College for General Practitioners, that most GPs are members of, has a published set of guidelines about gender-affirming care, and those guidelines are also being updated right now by a new special interest group that's just started within RACGP. That's a special interest group for trans and gender diverse healthcare, which is really great. So we're starting to see some movement within the general practice college around how they're addressing community as well, which has been awesome.
I am also going to jump in here and say that Working It Out has training on inclusive practice. They're local, so they understand the Tasmanian context, and they have excellent resources about inclusive practice. Their website is in the show notes. And if you're listening to all this and you're a GP or you're in some way connected to a general practice, you know what to do. But why should you? You're so busy. There's so much to be across. Why this area in particular?
Look, this is an area of medicine that makes you feel good often because your patients are going to love you for being a space that's safe. It's really easy to feel gratification working in a gender-affirming space. It's hard, and there's lots of complex comorbidity, and there's lots of challenges, but there's also a lot of gratitude. And I think sometimes it can be really difficult to get that in all areas of medicine and with all types of medicine. It's one of the unique areas where we get a lot of the warm and fuzzy feels frequently. And that's part of why it's such a sustaining space for me to work in, because it is one of those lovely areas where you get to see a lot of growth and evolution in people. That's really beautiful to be a witness to.
And I have had some really good experiences, even with doctors that haven't had, experience with trans people before. My previous doctor, for instance, who is now retired, I asked him if he'd had any other trans patients, and he said to his knowledge he didn't, but I could tell as well that he'd taken what he'd heard from me and he went and did his own reading, and I had my referral to get top surgery and things go through him, and he kind of did the work of looking up the WPATH and things like that to sort of know that what he was helping me do was within these approved guidelines and was actually going to be helpful. So, when there's people like that are able to do that little bit of extra work, that's really hopeful for us. Yeah, and it's just going to make it so much easier to navigate these quite complicated systems. So we really appreciate the work that you're doing there.
You don't need to know everything to do a good job and make a huge difference for your trans and gender diverse patients. I really hope that hearing from Dr. Hann and Oliver has moved you from feeling stuck to thinking, yes, I know where to and where to next. If you have any questions about this episode, and I mean any questions, please reach out to either Women's Health Tasmania or to Working It Out. Our details of how to get in touch are in the show notes, and we love hearing from GPs. Love it. I'm not even joking. If you thought this podcast was useful, interesting, or if you know someone who really needs to hear it, please share it. Or even better, rate and review it so that other people can find it more easily. Women's Health Tasmania made these podcasts in partnership with Working It Out, Tasmania's sexuality, gender and intersex support and advocacy service. The topics in this series were chosen by our crack team of trans and gender diverse advisors, and our music was composed by Chloe Allison Escott. This podcast is made in Lutruwita, Tasmania. Always was, always will be, Aboriginal land.